What would you say are some of the biggest misconceptions about gynecologic cancers?
Well, I suppose I would say that, that they only happen to your grandma. There are certainly, and, participating in the woman-to-woman program, I'm meeting young cancer survivors more and more. So, just understanding that this isn't something that you only start thinking about after menopause,
Right.
That plenty of people are diagnosed with these, at a younger age.
Hi, welcome to The Vitals, Mount Sinai Health System's podcast. September is Gynecologic Awareness Month, and these cancers affect hundreds of thousands of women every year. Yet conversations about them don't always get the attention they deserve. Beyond the statistics, every diagnosis represents a woman navigating not only treatment, but also questions of identity, resilience, and support. Today's episode is about these stories and the communities that carry women through their toughest moments. We're joined by Dr. Shari Brasner, an OBGYN at Mount Sinai, who suddenly found herself on the other side of the exam table as a cancer patient. She brings a rare dual perspective that reminds us cancer can touch anyone, and those who dedicate their lives to caring for others. We're also joined by Dr. Alison Snow, PhD, Senior Director for Cancer Support Services at Mount Sinai Health System, and works closely with the Women to Women program. Thank you guys so much for being here today. This is a really important topic for me that I'm excited to share about. Let's start off with you, Dr. Brasner. You are a doctor. You are an OBGYN, correct?
I have been an OBGYN at Mount Sinai for now 34 plus years.
Yes. And how did you find yourself as a patient? What was the story with that?
Well, I have a history of ovarian cysts through the years. I've had a couple of surgeries. They were always benign, and I thought I had another one. And I was actually in Boston visiting my son. He was in law school, and I went running, and I doubled over in pain and, was literally on the ground. And some people came over and they, "Are you okay?" And of course I was trying to downplay it. And I said, "I'm fine. I called my son. I called my husband. They're going to come get me." But they called campus security, and all of a sudden an ambulance arrived. And I thought, I am not going to have my surgery in Boston. Mount Sinai is my home. I did my residency there. I know that I will get,
Right.
VIP treatment, but I have to get home. And I said to my husband, "Let's get in the car. We are just driving home now."
Was it just pain, or did you feel like something had burst, something was terribly wrong at that moment?
I knew something was terribly wrong because we were driving home from Boston. It was a Sunday afternoon, and I called all of my patients who I had appointments with on Monday. And I said, "Look, I think it's likely I'm going to be having surgery today, but I'll probably be back in the office by the end of the week. So please just call my
Such a
office
woman.
tomorrow." Yes. Absolutely. Always about the patients first. And then I called my colleague, my gynecologic oncology surgeon who had operated on me for benign instances in the past. And he met me in the emergency room. And within 20 minutes, they had me in the operating room because I just acutely developed shoulder pain, which is a sign that you're internally bleeding. And, the poor resident who had to, help me get out of my clothing. I think he couldn't look at me for the rest of his training. But it was during COVID, and it was really strange because my husband had to just drop me off in the emergency room. He wasn't allowed in. I was in the operating room literally, within minutes. And when I woke up, they told me that it was likely benign, but it was strange because when they went in with the camera first, the laparoscope, there was too much bleeding in my belly, so they decided to go through my cesarean section scar and did a hysterectomy. And I had signed on the dotted line in the emergency room. You take anything you need.
Whatever
I
you
was
need to do.
55 years old. I had, long past needed, any of those organs. So when I woke up, they said, "We did a hysterectomy." Everything really
Was
looked
it for
benign.
bleeding purposes, or they felt
Well, they knew that something was very wrong
Okay.
because, there was blood all in my belly. Yeah. And they saw a small mass on the uterus, but they thought it was a funky, probably fibroid because those are so common. And then a few days later, I got a call from the surgeon, and he said, "This is really strange, but the pathology is a choriocarcinoma."
Wow.
And that is a diagnosis that you learn essentially in medical school for the exam, but it's something that you never see. I have never had a patient with a choriocarcinoma like this. So I had to sort of hit the books and refresh my memory about everything I had ever learned and anything I should know. And unfortunately, with very rare things, there wasn't a lot added over the course of literally the past, 30 years. But it was clear that I would need treatment. I would need chemotherapy. And within hours of him calling me, I had called a bunch of colleagues. I had all the imaging studies that I needed and, started my chemotherapy 1 week later.
Do you, just going back, because you said you had cysts before, the cysts that you had before, were those painful or were those just found on sonogram because you were getting your well care?
I mean, really, they were both probably what you'd call incidental findings. One, I was trying to get pregnant, so I was having some ultrasounds, and they said, oh, you have a dermoid, one of the most common benign, tumors young women can have in the ovaries, so I had that removed. And then there was even a cyst on my ovary at the time of my cesarean section that was removed. And at one other point in time, I think it was also an incidental finding, and the surgeon, removed that whole ovary.
Because it's common for women to have cysts. Even during their cycle, they
for
can
sure. And I deal with ovarian cysts every day.
Right.
And that's, kind of why I thought that this was likely, something similar. But
so what was your treatment? What did you have to do after the surgery, and how close to the surgery did you need the treatment?
So I started treatment 1 week after the phone call, and the phone call came probably about a week after my surgery. So within 2 weeks, I had been told that it was a very aggressive tumor, but very chemosensitive.
Great.
So it was a 5-drug regimen, and I had to do some of it as an inpatient because it got administered over such a long period of time. It needed, 12 plus hours, and none of the outpatient chemotherapy centers really are staffed.
You didn't say, I'm a doctor, I can do this for myself at home?
That would have been really nice because it is very different being a patient than it is being a doctor.
How do you think you handled that? Like, do you think that you were truly just a patient, or do you feel like you did better because you knew what to expect? Or potentially worse, I guess.
I think I worked really hard at certain aspects of just being a patient because I did not want to interfere with what my doctors clearly knew more about this. Like I said, I had to go back and, just do some reading. So I thought, let them do their job. That's difficult, but I do think that I navigated that part really well. I think what helped me was just what I alluded to earlier. I was able to call a colleague and get my imaging done, the same day. They didn't wait for my pre-authorizations to come through. They just said, come on over. That's sort of unheard of otherwise, for a standard patient. And I'm so very grateful for the luxuries or that, that special care that I did receive because I've made so many close relationships through the years with people in so many different departments.
For your exact disease state.
Yes, and others, an interventional radiologist. His wife had been a patient of mine. So when I called and I said, look, I've become really needle phobic and all of these needle sticks are just getting me crazy, I've decided now I want a port. He said, we'll get you on the schedule tomorrow. Yeah. And so, the relationships I had weren't just, things that I've called in, favors.
So your network that you curated over the years really is what helped your journey, is what you would say?
Yes. I think all of these wonderful people come to the aid of, patients every day. But every day, I'm so grateful that they just made it so easy for me.
So in your journey specifically, it wasn't, you were a good patient. You were taking care of yourself and going for your checks. But this wasn't something that was picked up. This hit you in the face one day.
Oh, yeah, this is out of the blue. There are really no specific risk factors. This tumor usually is associated with a recent pregnancy. I was 55 years old. My twins were 25 years old at the time. So, they had to go back and add a pregnancy test to my admission labs. There was, that wasn't standard for a 55-year-old woman. And of course, that's the marker for my tumor, and it was off the charts.
And that's not something you can screen for.
There is no screening. For very rare things, there's never really a screening tool. Screens are designed for populations at risk. And, there's just nowhere in the world that this is something that people walk around, sort of worrying about.
One of the things that Mount Sinai has that is so special is a program called Woman to Woman. And Alison, this is something that you're a part of. I really want to go into depth on that. But is that something that you were a part of either during or after your journey or since then?
I actually had not been involved in the woman-to-woman program until after my own diagnosis. And then, even though I knew all of those social workers, I really had no idea what they were doing because I'm not a gynecologic oncologist.
Right. You're sending them there.
That's right. I know how to make the appropriate referral. And then maybe I'll, see a patient, through the years, after a treatment. But I had never heard of the program and got involved really when I was finished with my treatment. And someone approached me and I said, this is amazing. I would love to pay it forward and help someone else who maybe is feeling some of the feelings that I had about, is this all going to be okay? How am I going to do this? How do I talk to my family? What else should I be thinking about? These were all things that I learned as a mentor, and hopefully I'm, giving my mentees, the benefit of my experience and my training.
Oh, I'm sure you are. We have this program called Women to Women here. I know that because my mother is a part of the program, and I want to talk to you guys about that. But can you tell us a little bit about this program?
Sure. The program was started in 2001 by Valerie Goldfein when she was diagnosed with ovarian cancer and felt isolated. And thanks to it's philanthropically based 100%. And it's a program that has volunteers and support. There's a lot of mentorship through the survivor volunteers. And then the social workers who lead the program offer financial assistance, psychoeducational programs. It's really grown and become such, I think, an incredible asset to the Mount Sinai health system.
How many patient volunteers do you have for this program?
There are currently 49.
Okay. And what about how many social workers work with the program?
There's 2 managers that support the program, and then we also have GYN oncology social workers in addition.
So I want to tell you guys a quick story. My mother is a patient here at Mount Sinai, and a couple years ago during COVID, she was doing Pilates and was feeling her T-zone and said, it feels very full down there. She knew something wasn't quite right. She had missed her annual check the year before because of COVID. So she called her gynecologist, went in, did a sonogram, and there was something kind of funny looking there. So he did a bunch of tests and said, yep, this looks like an ovarian tumor. I can't tell whether it's cancerous or benign, but we need to take it out. So she was scheduled for surgery 3 times, and they canceled 3 times for COVID reasons. And so finally I said, that's it. You're not having surgery up in Connecticut. I called one of the urologists that I used to work with, knows Dr. Stephanie Blank very well, got me on the phone with her. Stephanie said, this was a Tuesday. She said, I'll meet your mother on Thursday. I'll operate on her on Tuesday next week. She called me when she got out of the OR and she said, yeah, that definitely did not look as good as I thought it would. And it turned out it was a clear cell ovarian cancer. And I'll make the story quicker, but my mom, in and out of the hospital, she started chemotherapy a couple weeks later. And the type of person that my mom is she's just a living angel. She was wearing her cold cap at the Chelsea Infusion Center, miserable, and finally fell asleep on the Benadryl, and then woke up towards the end of her treatment and said, oh my God, I'm the luckiest person alive. And I said, why is that? She said, I'm going to be able to volunteer and mentor so many people through this. And I was like, oh my God, that's amazing. So we didn't actually, she had gotten a phone call before treatment, not before the surgery, that was quick, but before her chemo treatment, she got a call from someone that said, the worst of it's going to be the cold cap. You have to know this, 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 and this. This is what to expect. So she already had someone. And then within 2 weeks of finishing her chemo, she had already had like 3 people she was volunteering with. And I feel like if you guys were going to give out gold stars for patients, it would be, my mom would get one of them, right?
Yes, absolutely.
She loves your program. She participates in everything she possibly can. She would like run the group if you let her. I will tell you that going through something as scary as that and as difficult as that was made so simple by this program. And it just keeps on giving. So thank you.
Yeah, no, for me, I remember the first time, I interacted with a new mentee, and she looked at me and she said, I've never met someone who survived their cancer. I always hear these stories of so-and-so had cancer and died. And I said, well, here I am, look, like I'm not making any of this up. My hair is all grown back. I am exercising. I am working. I worked all through my treatment. Wow. I said, so, I'm living proof that you can do this. You can beat this cancer. And, she just, it was like a whole like her whole world, a switch flipped, and she was like, yeah, I think you're right. I can do this. You did it. I will too.
What do you think the biggest need is for this group? Is it someone who's gone through it, letting them know what the next steps are going to be? Is it just a sounding board? What do you think the people are actually getting out of it the most?
I think what Dr. Brasner said really resonates. I think for a lot of patients, they really feel like a cancer diagnosis is a death sentence, like they don't necessarily have the support in their own families or, social connections. So I think the fact that this program really offers them that peer mentorship, in addition, a community where they can really have that kind of support. In addition, some patients really benefit from like the financial assistance aspects of it. So there's practical things that are really helpful.
Like what are some of the things that patients need financial assistance for?
So there's a new program now where they're helping them with cleaning their homes. So if anybody really needs that kind of support, Jillian and Rachel have just done such a tremendous job in really finding all of the things that really can prevent a patient from having a good experience and just like helping them figure those resources out. So they have financial support for transportation, for them to get to appointments, to cover sometimes, co-pays if they need help with that. And that can really relieve the stress and anxiety that people have, going through cancer treatment. So I think those are just a few of the things, but there really are so many facets of the program that I think are just so beneficial.
When I think women and cancer treatment, I think hair loss.
Yeah, so I'll tell you about one of the newest programs.
Yeah, tell me.
Women to Women just launched a wig program, and they've partnered with an organization. I had donated my wig when I was finished with it to this organization, and we're being trained, if you're interested, the volunteers, in how to advise. But for me, the worst part of my chemotherapy was the hair loss because I wanted to work.
Did you wear the cold cap?
I was not a candidate. It was 5 drugs. There was no way a cold cap was going to save my hair. They said it's going to be about 2 weeks after your first chemo that you're going to notice your hair starting to change. And literally 2 weeks to the day, I ran my hair through my fingers through my hair, and the first clump came out. And my husband helped me shave my head, and my best friend had taken me the day before my chemo started for a wig. I never realized how expensive a really good scalp prosthesis is, what they call it in medical terms. So I was eligible for some reimbursement, but for some women, it's prohibitive cost. So this wig program gives them, options that they would never have had. And it's really only a couple of months old, and already we meet once a month, the volunteers, on a Zoom call. And just the last one, we were talking to some of the wig volunteers, and they said it's, been just amazing to help women, feel like themselves through the treatment.
Yeah, somebody donated one to my mom too. I think I'm not sure if she ended up wearing it, but she was just so touched that she got something. Yeah. What's the training like for this program? How do you train to become a mentor in this program?
Well, Jillian and Rachel have a terrific, sort of program. And, we met for a couple of hours. They gave me a handbook. But really, it's meeting each patient where she is and finding out what she needs. So I usually reach out by text first, and I say, I'm a volunteer with Women to Women. Would you be open to chatting? And usually they've been approached by one of the social workers or referred to the program, so they kind of know what Women to Women could be. And I've had mentees that I talk to frequently. I've had mentees that I meet, for lunch, or we go for walks. And I've had others who, say, you know what, I'm really doing okay. Thank you. I really appreciate you reaching out, but I don't need a lot of ongoing support. And so I respect, what each person needs. Every year around the Jewish holidays, one of my mentees I know is, observant, and I'll send her a note and just wish her happy holidays. And others I, reach out to more regularly.
What year did it start in again?
2001.
Okay, so what does it look like since then? How many members?
I think it's just really grown tremendously from the beginning. I think also as treatment advances, more and more people are surviving. And so I think Jillian and Rachel, again, have really been able to get so many volunteers with different types of GYN cancers. And so I think the program has, like I said, also grown with the different services, like the WIG program and the fact that they have a house cleaning program and all these psychoeducational programs every month. They just had a great 12 o'clock with Dr. Gans on survivorship. So There's just so many different facets, like I said, about
So the
how it's
Zooms
grown.
that my mom speaks of, these are these like monthly Zooms, right? But then you also have the in-person ones, like those catered events on the Upper East Side every now and then. What's
There's the
that?
reunions.
That's a reunion.
That's a reunion.
Right. Those
Okay.
those happen less frequently, but there's a full calendar of events. The ones that your mom participates in are really for the volunteers.
Okay.
And we meet and talk about issues. You know, somebody may be having a complicated relationship with their mentee, and everybody will listen and give them, you know, some ideas and thoughts about how to handle that situation. But there's a full calendar of events for patients still undergoing treatment, recurrent cancer, how to, you know, live with cancer. You know, I think they're literally, you know, almost every
Like all
day
the
of the
topics.
month, you could, you know, sort of log on and join a discussion group. So again, it's, you know, there's something for everyone. And, you know, I only participated as a volunteer.
Is that hard to do? Is that hard to sometimes not open up your mouth and be a doctor?
You know, I'm happy to just be a listener, but sometimes we go around the, you know, the Zoom room, you know,
Yeah.
and everybody has something to say.
I know that's actually one of the rules. Like you can't give, like in order to be a mentor, you can't give any medical advice. You
And
like
in
walk in
fact,
with different hats on
Some
certain
of my
days.
mentees don't know that I'm a doctor. I don't share it unless it comes up very organically in the conversation, because I don't think it's important. I'm reaching out as a cancer survivor, not as the OBGYN hat, you know. So I would say that probably at least half of the women I've interacted with through the years don't know what I do for a living.
How many women have you interacted with over the years?
Again, some of them it's a
Even if it's just a one phone call.
probably 7 or 8.
Wow.
And you know, and some it's an ongoing, you know, just touching base. You know, some of my patients aren't as fortunate as I was. They don't have family support, so I make sure, especially around holidays, you know, how are you doing, what's going on. You know, I have one patient who continues to struggle, you know, with her diagnosis. And I've met her. She lives on the Upper West Side. So, you know, rather than it just be through text or a phone call, I said, let's meet in person. And now when, you know, she sees me on Zoom, she'll send me, you know, a little private message saying, it's nice to see you.
Oh, that's
You know,
so
so,
nice.
yeah.
What a beautiful program. Now, you guys actually have a reunion coming up, right?
Yes.
So when is that, and what happens at these things?
I actually didn't bring my phone in. I can't check the date. It's usually on a Saturday morning in the fall, so it's probably sometime coming up the end of September, October. We can get that
October,
date for you
yes.
in October.
That's okay. That's okay.
And they rent out. It's kind of like almost like a rec room
Right.
in a school on the Upper West Side, and volunteers as well as all of the, you know, mentees through the years are invited to come back, and there's a guest speaker. And I think this year the focus may be on hair, so there's probably, you know, a specialist coming in to, you know, talk to us all, and it's just the warmth in the room, the camaraderie. You know, it could be a complete stranger, but you know that you're sitting at the table with someone who's walked a path that's pretty similar to yours.
Right.
And it is the great equalizer. You know, cancer strikes everywhere.
So it is it's Gynecologic Cancer Awareness Month. What do you want the listeners to know about how they can help themselves? I know you said some of these things you can't screen for them. So what are some things that they can do that they're in control of?
I mean, the reality is like every other cancer, good health habits play a huge role in terms of reducing your risk. I mean, we all know exceptions to that rule, and I think I'm one of them, but healthy diet, healthy exercise habits, you know, not smoking, not drinking in excess. I mean, these will have tremendous obvious health benefits for your cholesterol or your weight or, you know, your BMI, but they all will lower your cancer risk as well. So they're not to be sort of minimized or overlooked. You know, when it comes to rare cancers, and ovarian cancer, while it's the scariest probably of them all, is still one of the rarer, you know, gynecologic cancers.
So uterine cancer or endometrial cancer is is the most common. Then ovarian, then vulvar, then vaginal.
Well,
Is that correct?
Yes, and you left out cervical.
I did.
Yes.
So this is
Although
why I'm
in
with the
this
doctor.
country, you know, Pap smears, you know, are a
Oh, wait,
very
cervical. Here
effective
we go.
tool.
Yep.
Oh, it's there. Yes, endometrial cancer is really well known because it's the most common, but it's not the only kind of uterine cancer. The uterus has a lot of different cell types, and in fact, my cancer originated in the uterus, but it's, it's sort of at the bottom of the list. You've got those endometrial cancers, the cancer of the lining of the uterus. You have sarcomas. You can have, and then the other cell types.
So when women of the appropriate screening age group go to get their pap smears and they go for an exam, is that just looking at the cervical cells because they're swabbing the cervix, or is that getting something from the uterus as well?
No, in a non-menstruating woman, a pap smear sole purpose is to screen for cervical cancer. Okay. The bimanual exam, when the doctor may put a hand on the belly and hands or fingers, in the vagina, feeling those internal organs is another way to screen for other gynecologic cancers. But it's very difficult to feel a small mass, let's say like the one that was on my uterus. There's no way I could expect that somebody would have felt that. And perhaps even your mom. I mean, she only had symptoms probably when, she had bloating and,
Well, she's thin and fit and feels like she works out, so she knew. I can imagine how that would be easily missed in someone.
The stories you hear, there is a huge power of denial, and I mean, again, your mom has a great story, but the vast majority of ovarian cancers, are diagnosed in a very late stage.
Okay, so let's just go through these. So for vulvar cancer, that is the area outside of the vagina, the area that you can see.
That's right.
Is that something that it would be visible? It would look like a mole? What would that look like?
Yes. I mean, the classic teaching is that 3% of melanomas are found on the vulva. And really, it's the skin cancer that I've diagnosed in women that's my strongest argument for my postmenopausal patient who says, why do I need to see a gynecologist? I had a hysterectomy. I don't even have those organs. I said, but you still have skin? And no one else is looking at it, probably not even your very thorough dermatologist. And I have picked up skin cancers of the vulva.
And the vagina. Vagina doesn't get removed with a hysterectomy. It's still there.
That's right.
How is that? Is that bleeding? How does one find that?
No, those can present as either itching or bleeding. They're erosions of the skin. Good physical exam because we are feeling, for things that don't feel just right.
Right.
But again, you're talking, about not the most common cancers, things that people can feel with their own fingers. Hopefully they'll bring themselves in, and just say, does this seem right?
So then we talked about cervical, and typically the age that's getting cervical cancer is typically the age group that should be getting pap smears, correct?
Well, pap smears start at 21.
Mm-hmm.
We think of cervical cancer, we know that it is HPV, human papillomavirus mediated. That makes it very different from other cancers and certainly from the other gynecologic cancers. We think of it really as being part of a sexually transmitted disease. HPV is the vector. So we now have, tools we can do. Yeah. Yes, we not only can start vaccinating adolescents, both male and female, and that will, in the long term, dramatically, and already has, cut down on cervical cancer rates and also cut down on, albeit rare, penile cancer rates. But, the pap smear will often be done in conjunction with an HPV test.
Okay.
So if you know that you have one of these high-risk HPV types, because cervical cancer develops so very slowly, you sometimes have years to offer interventions that will eliminate the risk of ongoing concern. So you can remove parts of the cervix and essentially eliminate those cells that are HPV infected and thereby eliminate the risk of cancer.
Okay. And then back up to the ones that you can't see or feel so much. So ovarian, less common, typically more aggressive.
Older patient.
Yeah. So how do they typically present?
They present with already metastatic disease, stage 3 or stage 4. Ovarian cancer is known for spreading throughout the abdomen. So women will often present with what's called ascites, big swollen bellies filled with fluid, because those cancer cells have affected essentially all the lining around the organs. Ovarian cancer can be found in the lungs, it can be found in the brain. So, that diagnosis is staged surgically. You have to have the operation to see what organs are involved. And then they remove anything that's visible so that you're hopefully left with just micro disease that chemotherapy then can hit.
So it almost feels like Gynecologic Cancer Awareness Month isn't so helpful. Because if these are things that present so late, what could we do to raise awareness of maybe, or is it just research? How do we do better?
Well, there are mechanisms that I can talk to young women about that we know help reduce risks of cancer.
Okay, what's that?
Oral contraceptives are shown to dramatically reduce the risk of ovarian cancer later on in life. It also lowers the risk of endometrial cancer, that cancer of the lining of the uterus.
So it's clearly hormone mediated.
Well, it's that ovulation probably plays a role, and the birth control pill suppresses ovulation. So we think of ovulation, I don't want to get too detailed, but we think of each ovulation, each release of an egg, as a little injury to the surface of the ovary. And the constant repair mechanisms that are there, something goes awry. And so if you suppress ovulation, sometimes for years on the birth control pill, you have far fewer injuries and therefore far fewer ways that repair could go wrong. So birth control pills are a valuable tool. If a young woman comes to me and says, my grandmother had ovarian cancer or my mom had ovarian cancer, birth control pills are part of our armamentarium.
So from like a community outreach perspective, if finding some of these cancers really only happen later in life, how do we go about getting the right information to people to reduce this later?
So we definitely have a community outreach and engagement team that goes out into schools, into the community health fairs, and gives this kind of information in terms of HPV education, screening, what you can look for. And I think a lot of it is also knowing your body, like your mom knew something was wrong, and like the denial part, right? Like going to your primary care doctor, your GYN, and sharing what you're noticing about your body. So I think part of it is like that educational piece, and then also kind of listening for signs and symptoms that you feel like something not right. But definitely there's always room for education, and that's a big piece of like the community outreach and education for Tisch Cancer Center.
So diet, exercise, oral contraceptives. Let's talk. We did an episode on alcohol, how alcohol is a risk factor for cancers. Smoking, is that also a risk factor for these types of, okay.
Yes. I mean, HPV vaccines,
Yep,
safe sex, condom use for young girls. I mean, they don't realize that, HPV can be a killer. And even our best vaccine right now is known as Gardasil 9. It will protect against 9 subtypes, but we think there may be about 70 different subtypes of HPV, so nothing's going to be as good as limiting the number of sexual partners and using condoms. And that's a message that I will tell you for years, I mean, we're failing. It goes into the schools, but it's not translating into action.
Well, I think as much as we'd like to not believe it, I mean, I've had this conversation with my children, explaining that condoms just aren't for pregnancies. Like, really, people don't really get that. They understand the STD thing, but they think of it as just that in that moment. But when in reality, it could affect the rest of your life.
Yeah, and I remind the young girls that I see, we have treatment for gonorrhea and chlamydia, but we don't have a way to eliminate HPV or herpes simplex virus. And that's a diagnosis that still carries so much stigma. I mean, it's really, it's so difficult to manage these young girls who feel
But it's also more than that. You just said that something as physiologic and normal as ovulating is technically causing damage. So then, you can treat gonorrhea and chlamydia, but you're also scarring your organs. You're hurting your organs by getting these things. So these are damaging things, even though some of them can be treated. Does that lead to cancer later? All these effects that can happen from these STDs?
I don't think we've linked anything other than HPV specifically to cancer. And I don't want to, scare my patients. I don't want to make them sexual cripples. But I also, know what goes on college campuses, and I want these young girls to understand that, a diagnosis of herpes sort of stays with you for life. Yeah. I mean, it's moving away from the gynecologic cancer, aspect, but, yes,
we can
condoms.
Talk about STDs also.
Condoms do more than just prevent pregnancy. That's the bottom line.
What would you say are some of the biggest misconceptions about gynecologic cancers?
Well, I suppose I would say that, that they only happen to your grandma, I mean, there are certainly, and, participating in the woman-to-woman program, I'm meeting young cancer survivors more and more. So, just understanding that this isn't something that you only start thinking about after menopause,
Right.
that plenty of people are diagnosed with these, at a younger age.
What would you say that?
I think also that Dr. Brasner is like living proof that you can go through a rare disease, a rare cancer, and still, be a mentor and, be there for the people who are so worried about a new diagnosis. So I think a lot of misperceptions around, what does it mean to be diagnosed with GYN cancer and survivorship.
Right. What, I think I know our health system does an incredible job treating patients, advocating for patients, everything from like the diagnosis all the way through the treatment. What do you think that we, and I don't mean we Mount Sinai, I mean we as a whole, could be doing better for these patients?
I think just like getting the word out is one of the things. I know as the Tisch Cancer Center Community Outreach Program, like that's something that we really work towards, getting these messages out about screening and education. I think in terms of the woman-to-woman program and the work that they do, I can't think of anything that they could do better because it's so comprehensive.
So I guess you're probably right. Like they're doing such an amazing job with people that have the diagnosis, but it's really the outreach before is where the work has to be done, and that's what you focus on. What do you love most about your job?
For me, I think it's all of this, like the opportunity to touch people's lives and to make them better for their cancer experience.
When you guys do community outreach and you're educating young girls, do they engage with you, or are they just sort of listening and taking it in?
I think it's hard. I think there's this great program, the Knockout Cancer Day, where we had a high school come and visit, and I think that the high school students were very shy at first, but they found different ways to engage them in these kinds of conversations and the learning about cancer. But it's definitely, I think, challenging to talk to certain age groups about cancer.
What's like the most appropriate age group to start with?
I think high school.
Okay. Yeah. Did you want to add to that?
No, I just had a very unique experience being a patient. I thought was really difficult, and I'm educated and I'm a doctor and a gynecologist at that. And yet when I came home from the hospital, or finished one of my treatments, there were often some medications I had to take at home. And my daughter and I would literally have to take a big Post-it sheet and put it on the wall because I couldn't remember if one of the medications was something I was supposed to take 3 times a day, or was that the medicine I was supposed to take once a day for 3 days? And I kept going back to the idea, what if English wasn't my first language? Mm-hmm. What if I didn't have the ability to go onto, a website and just look that up or get in touch with my doctor very easily? There were so many times where I stopped and I said, wow, I'm really grateful. This is really challenging. One of my medications was going to be delayed. The pharmacy didn't have it. I had the information I needed to be able to say whether it was okay to delay it for a day or not. And I was fortunate that I had the credit card to say, well, it's not going to be approved in time, but I need that today.
I'll take that.
Let's take care of it and I'll deal with that later. Yeah. So often I just kept going back to this concept of just remember how grateful you should be.
Medical literacy, socioeconomics are huge in this. I mean, I, as a surgical PA, I see my patients before discharge. I talk to them after discharge. I see them in the office afterwards. I cannot tell you how many times I have patients that said, oh, well, my seizure medication wasn't ready at the pharmacy for 2 days, so I didn't take it. And they ended up back in the hospital with a seizure. Or they weren't sure how to take their steroid taper, so they just didn't. It's so common. And I'm educating them. I'm doing a really good job, but it's still not perfect.
I was told all of these things, but, when you are the patient, your head is spinning. And, I really sort of took that to heart and understood it, firsthand, probably seriously for the first time in my life.
We know that with breast cancer that there are certain genetic risks. People go through genetic screening. I've gotten tested for it. I did the whole thing. Are there any genetic testing that we can do to see if people are at higher risk for these cancers?
Well, BRCA1 and 2 do confer some risk for not just breast cancer, but for ovarian cancer as well. But we really don't otherwise have genetic tests. I mean, again, I'm not a gynecologic oncologist, so I'm not, that's not my subspecialty. There are families that, if you did a detailed genetic history, you could, sort of find that there was something going on genetically, whether we have a test for it or not. And those patients, may be able to get identified and screened, at a schedule that you wouldn't necessarily recommend for the general population.
So, like, if someone's BRCA positive, maybe you would get yearly transvaginal ultrasounds on them.
That's right, because then you're justified in applying a test that may have a false positive. You're willing to accept that in a high-risk patient.
Right.
So, yes, all of a sudden that becomes a very routine test.
Right. Okay. Yeah, that's a really difficult concept. So, for people listening, if you were to screen all of the patients that came in and had an exam with a gynecologist and you send all of them for transvaginal ultrasounds, the likelihood that you're going to pick up anything significant is very, very low. But if someone's at high risk of having something that can be picked up on transvaginal ultrasound, then they should be getting them yearly. Do you have a daughter?
I do.
Okay, so is there any risk? Is she at any increased risk based on what you went through?
For my particular cancer, I don't think it confers any increased risk for her. I don't really know what to tell her to do differently, except, she held my hand through all of it. So I'm sure that she is thinking these things and is a different person, now than she was, prior to my diagnosis. But hopefully, she also watched, that she'll know that she can fight and win. And so, we'll deal with whatever comes her way.
What are a couple things, one or two things that you want every woman to know about gynecologic cancers and survivorship?
You're never alone on this journey. And whether it is a woman-to-woman program or your own family, your friends, your colleagues, I know in my case, people came out of the woodworks to share their own, stories, drop off food, whatever it was. You're never alone. You may feel that way in your darkest hour, but, seek out the support that is definitely there because I think it makes such a difference in the experience.
Yeah.
I think that is the woman-to-woman motto, that you are not alone. So I think that what Dr. Brasner said, that there are so many resources to support you and to reach out so we can get people connected to the resources.
Ovarian cancer is very personal cancer, and to have that support is really important. I think that's what really does set Mount Sinai above. Thank you so much for being here today. I appreciate it. That's it for this episode of The Vitals. I'm your host, Leslie Schlachter. Subscribe to The Vitals and Mount Sinai's other podcasts on YouTube, and find us on Apple Podcasts, Spotify, or wherever you get your podcasts. To learn more about gynecologic cancers, visit the Center of Excellence for Gynecologic Cancer and Cancer Support Services. To learn more about the Women to Women program, click the links in the description below.